Everyone. I'm one of the guilty ones who did not send my presentation. Sorry, Julio. Let me just get oriented. I think I have a pointer. Yeah. It's really a great pleasure to be here and to be in Vancouver and to be in your home, Julio, and especially to meet so many wonderful colleagues. I came late last night and missed a lot of the presentations and the dinner talks and so on, but I was just heartened to see so many colleagues from so many parts of the world. What I'm going to try to do today is to very briefly go through some of the evidence that we have available in terms of the whole issue of ART and prevention, and try to also identify some of the gaps in our knowledge and a way forward to answer some of the key questions. I have to start by remembering the Vancouver conference. For those of you who are as old as I am, have remarkable memories of that conference right here in the city in 1996. My own daughter was a lovely 2-year-old. Now she's a very difficult 16-year-old. So it's been many interesting years. But this was a transformational moment for many of us in this room who take care of people living with HIV and offered a gleam of hope for transforming HIV from a death sentence to a chronic, manageable condition. So it's really great to be back here after so many years. It's also important to remember another landmark, which is the International AIDS Conference in Durban in 2000. And another very important moment in time when a global commitment was made to expand antiretroviral therapy and provide access to the millions who really needed it, largely in poor countries around the world. Building on the findings identified at the Vancouver meeting. We know the success that's been achieved largely due to the commitments of funders, global funders, the US funders, and multilateral funding, as well as also the commitment of the people on the ground, the ministries of health, the people working at these health facilities, the people working with organizations within the countries themselves, and many, many others. And this global commitment has led to this remarkable achievement of going from, at the end of 2002, of this very small sliver of individuals in sub-Saharan Africa in red receiving antiretroviral therapy to, by the end of 2009, 4 million people in sub-Saharan Africa in red here receiving antiretroviral therapy. This is an achievement of historic proportions in public health. There's also been good news in terms of prevention, believe it or not. I think these are data, again, from UNAIDS that show that the change, this map shows change in HIV incidence. And in green, countries that are colored in green are countries where there's been greater than 25% decrease in HIV incidence, where those in gray are where there's been stable or no change in incidence, and then those in red where there's an increase in HIV incidence. And the news is largely good, although not great, but good, in that in many countries in sub-Saharan Africa, there appears to be, we're going in the right direction with a decrease in incidence. Whenever I show this slide, I always point out to the United States, where we have not seen a decrease in incidence or new numbers of annual new infections for a decade or more. Again, highlighting some of our own limitations in the US in terms of tackling this epidemic. And we, of course, know that it's estimated there are about 2.5 million new infections in adults and children every year. So we have a long way to go in terms of prevention, as well as also in treatment, as you are well aware of, with only about 35% of those who need treatment today getting access to treatment. So let me then just outline briefly what I'll go through in the presentation. I'm going to show you some of the data that provide evidence for ART as a prevention strategy, evidence for benefit and risks of early ART for persons living with HIV, because as you know, of course, using ART for prevention implies that we're going to treat people living with HIV with antiretroviral therapy. And then move on to gaps in our knowledge, challenges for implementation of this potential strategy, and then a way forward. There have been many, actually, studies and much written about the potential of combination antiretroviral therapy as a method or as a strategy to eradicate HIV epidemics as early as 2000. This is one paper from 2000. Could widespread use of combination antiretroviral therapy eradicate HIV epidemics? And this is from 2001, modeling the effect of combination antiretroviral treatment on HIV incidence. So there's been a lot of interest for close to a decade or more in terms of the potential of treatment as prevention, largely through modeling studies. But probably the whole discussion was catapulted to a different level, I think, with the model that was published by Grenogen. Oh, he's here in the room somewhere, Ruben, in the Lancet of in 2009, that utilized data from South Africa. And as all of you are well aware, in that model, based on assumptions of annual testing for all individuals greater than 15 years old, all HIV individuals started on ART immediately, irrespective of HIV disease stage, a decrease of 99% in infectiousness, high level of adherence with ART, and low failure levels with first-line ART. Based on these assumptions and utilizing data from the South Africa epidemic, the authors were able to provide very intriguing findings that, for example, with anticipating that this would be associated, the strategy would be associated with substantial decrease in HIV incidence and prevalence over time in a country like South Africa. Now, in addition to the modeling exercises, there have also been several ecological studies that also support the promise of ART for prevention. And these are data from right here in British Columbia that show, you probably can't see the small print, but on this axis and the y-axis are number of patients on ART, on this axis the number of new HIV diagnoses. You can see in the blue line, with expansion of individuals on antiretroviral therapy, there's been a decrease in the number in red of new HIV diagnoses. And particularly, and this is here in green, are new HIV diagnoses in anyone who's ever been an injection drug user. So this is ecological evidence over time that with expansion of antiretroviral therapy in this community, there's a decrease in the numbers of new infections. There also are data from San Francisco and from Das and her colleagues, and she's here as well, that looked at the correlation or the association between viral load and numbers of new infections in San Francisco. Looking at here in this figure on your left is the total viral load over time and the percent suppressed viral load amongst those individuals who had a viral load measured. You see over time there's been an increase in the proportion of individuals to about 78% who have suppressed viral load. And then looking at the mean viral load again over time from 2004 to 2008, you can see there's been a decrease here based on their data in the number of newly diagnosed and reported HIV infections as well as in HIV incidence. Again, ecological data supportive of the concept of expansion of access to antiretroviral therapy, and particularly in this, the hypothesis that the authors posited here is with more suppression of viral load in the community was associated with decrease of new infections. There also are data from elsewhere. This is the effect of ART on number of new infections in Taiwan. And at this point in time, the government decided to provide free antiretroviral therapy. And you can see again from these data that were published in 2004, is that with availability of free antiretroviral therapy, you can see here what happened to the trajectory of numbers of new cases of HIV in this country. So again, ecological data supportive of the concept of expansion of antiretroviral therapy, suppression of viral load, potentially in a community or a subset of individuals within the community who have viral load measured, is associated with fewer numbers of new cases of HIV infection. I think there are even more compelling data, I believe, from studies of discordant couples. And one of the early studies was this one that was published by Tom Quinn in 2000, New England Journal of Medicine, that looked at the association of plasma HIV RNA levels on the x-axis and HIV transmission per 100 person years in discordant couples, in all of the couples, male to female transmission and female to male transmission. This study was done prior to the era of antiretroviral therapy. This is just HIV RNA and risk of transmission. And as you can see here from this figure, is that when you look at any of the groups that he looked at, that there was a gradation of an increased risk of transmission or higher transmission rate with higher plasma HIV RNA. Here at the highest level is greater than 50,000 copies. The lowest level is less than 400 copies. There were some transmissions at the lowest level of what was then undetectable viral load, but obviously you can see the rate of transmission was much lower. So this was in the absence of ART. This is just the association of plasma HIV RNA and HIV transmission in discordant couples. Even earlier than that, in 1994, actually, amazingly, there was a study of HIV transmission in serodiscordant couples, a very small study that included 436 HIV-infected monogamous men and followed their female partners, and noted 27 women who seroconverted, a rate of about 3.7 per 100 person years. The relative risk of transmission was obviously increased with no use of condoms, but interestingly, just with use of monotherapy with ZDV, there was a protective effect in terms of transmission from the male partner to the female HIV uninfected woman. More recently, there's been many more accumulating data from discordant couples. This is one study that was presented at CROI in 2009 of discordant couples in Rwanda and Zambia. As you can see here from this curve, this is an observational study of discordant. About 3,000 couples were followed for a median of 512 days. And you can see from the data that, and the figure on the right, is that there was a decrease in the risk of HIV transmission with the use of antiretroviral therapy, about an 80% protective effect of use of antiretroviral therapy. What's interesting is that also in this study, sexual risk behaviors were lower in those who were on antiretroviral therapy. This is important because there's been concern about the whole issue of disinhibition with use of antiretroviral therapy. So based on this study, actually, both antiretroviral therapy as well as change in behavior independently were associated with reduction in HIV transmission. Not all the data are consistent. This is a smaller study of only 1,287 serodiscordant couples, also an observational study from China, where the index partner, about 71% of the index partners with HIV were on antiretroviral therapy. There were 84 seroconversions with about a 1.71 per 100 person years of transmission. Keep an eye on the rates of transmission in discordant couples because they're quite variable actually from study to study, which is interesting. And of course, no consistent use was associated with a higher risk of transmission. But interestingly, use of antiretroviral therapy was not significantly associated with HIV transmission. But again, this is a much smaller study, and remember, 71% were on ART. Studies have become more sophisticated with time, and this is probably the strongest evidence from a serodiscordant study that looked at ART and linked HIV transmission, where the virus isolated from the index case and the newly infected case were similar or identical or similar, demonstrating that the transmission actually occurred within the discordant couple. About 3,000, more than 3,000 discordant couples, again, observational study. HIV positive partner had a CD4 greater than 250. Remember, this is not a randomized study, but however, some of these, and not on ERT, and of those patients, of those individuals, 349 of the HIV positive partners initiated antiretroviral therapy. There was only one linked HIV infection with a rate of transmission of 0.37 per 100 person years after starting ART. So essentially, this study, which looked at linked transmission within discordant couples, showed a 92% reduction in HIV transmission risk. What's very interesting is actually this very recent study that was just published utilized the same data from the discordant couple study from which I just shared some results with you, which is, I think, the first time that anyone has shown an association between genital HIV RNA and risk of HIV transmission. And this data, if you look at these figures, this is female to male HIV transmission, male to female HIV transmission. On this side are plasma HIV RNA levels at the different levels of plasma HIV RNA. In these panels here is endocervical HIV RNA or seminal HIV RNA. And on the y-axis is HIV transmission incidence. You don't need to see the actual numbers, but as you can see, there's also the same gradation of an association between both plasma HIV RNA as well as genital HIV RNA and the risk of HIV transmission. And the association between genital HIV RNA and transmission was an independent association when adjusted for plasma HIV RNA. It's important to just note that there were actually some transmissions that occurred in couples where there was undetectable genital HIV RNA. While all of the discordant couple studies that I showed you really were observational studies, there's one ongoing study, HPTN 052, which is looking in a randomized manner at the whole issue of transmission in couples, in serodiscordant couples. And the study has enrolled discordant couples from a variety of different countries listed down here, with a CD4 between 350 to 550. And these HIV-infected individuals and their serodiscordant partner, they're randomized to immediate ART or deferred antiretroviral therapy. Immediate antiretroviral therapy is initiation between 350 and 550, and deferred ART is less than 250. The endpoint are HIV transmission to the partner, as well as some endpoints within the HIV-positive individual himself or herself. It's important to note that this design was selected because obviously for people with lower CD4 cell count, ART is indicated. So this is the only way you can look at this question in a randomized manner in an ethical way, is to take individuals who otherwise would not be eligible for ART for their own benefit. Now, it's been quite controversial, the whole issue of the contribution of transmission within discordant couples and their impact on the HIV epidemic. There's some studies, one study that was published a few years ago by Kristen Dunkel from data from Rwanda and Zambia that estimated that about 50% of incidents in in these countries where she looked at the data could be attributed to transmission within discordant couples. However, others have disagreed with this estimate and others have modeled this differently. But it's important to also look at the data that we have in terms of concordance or discordance in couples based on demographic and health surveys. And this is from a recent paper in The Lancet, different countries based on DHS data. And you can see here various countries, the number of couples in the survey, HIV status concordant negative, and the majority, obviously, in all of the countries are concordant negative. Concordant positives, and you can see this varies from as high as in Lesotho of 20% to as low as 1% in Ghana. And then discordant male positive or discordant female positive. You can see obviously that there are fewer, much smaller proportion of these couples are discordant. But it could be as high in Lesotho as about 8% discordant male positive, but as low as 1% in Ghana. This has an impact, obviously, on the potential, the impact of transmission within couples, in couple studies, on the control of the HIV epidemic as a whole. And I think it's important to keep in mind that there's a difference there. In a very interesting modeling that was published recently, the contribution by discordant couples to the HIV epidemic was modeled by Coburn, Gerbery, and Blower. And what they proposed is that the proportion of a population in stable relationship, whether they be concordant or discordant, just a proportion in stable relationship here on the x-axis, could influence and would influence the proportion of HIV incidence due to transmission in discordant couples, in stable discordant couples. So for example, if you think that in a country like, let's say 40% of couples in Ghana are in stable relationship, you can see that in Ghana, the impact in terms of HIV incidence in discordant couples on the proportion of HIV incidence in that country due to transmission within those couples may be as high as 34%. But if you took the same level of proportion of stable partnership in a country like Rwanda, the impact would be maybe about 20% only in terms of the HIV incidence. So I think it's important to keep in mind the whole evidence in discordant couples, the impact within discordant couples, but also what would be the impact on the population as a whole, and how that may vary by country, as demonstrated by this interesting modeling work. So I'm going to shift gears now and talk about the other side of the coin. We talked about kind of the prevention, use of ART and prevention, the data to support ART for prevention. what about the data to support use of ART early in people living with HIV themselves? I mean, those are very important two sides of the coin that we have to keep in mind as we move forward. As you all know, the WHO recommendations for when to start antiretroviral therapy support starting ART in patients with HIV who have a CD4 less than or equal to 350 cells, irrespective of clinical symptoms. Actually, this was a strong recommendation with moderate quality of evidence, and it really is based on one single center study, the CIPRA study from Haiti. There are no data on early use of antiretroviral therapy in developing countries and their benefits versus risk, no clinical trials, and no observational data either. So there's very little data out there on the benefits and risks of early ART in developing countries. Now we know that recently we all learned that our old ideas of kind of this long latency period where there's a silent asymptomatic period in the course of HIV disease, that has changed. And we now believe that there's ongoing morbidity during this assumed long clinical latency period based on results from the SMART study initially that demonstrated the impact of non-AIDS events in patients with HIV. I think the impact is, it's important to think about why is there and what's happening in these patients. And these are data from Hopkins observational data looking at death due to non-AIDS events and death due to AIDS events. As you can see here in this figure is that at lower CD4 cell count, when you look at the mortality, the most AIDS events are they're responsible for a much higher proportion of mortality. While at higher CD4 cell counts, obviously mortality is much lower, but non-AIDS events are predominant as the cause of mortality. So there's a shift in terms of the causes of mortality based on the CD4 cell count. And the hope is that by using antiretroviral therapy earlier in HIV disease, that this would impact on the AIDS as well as particularly the non-AIDS event. But this is still a hypothesis, and we have some very little evidence from observational study, but this is still a hypothesis. But this is the critical issue is, will early antiretroviral therapy have an impact on, particularly on mortality, and particularly on non-AIDS related mortality? Now, there are observational studies that are very interesting. And one of them that look at ART use and the risk of death at higher CD4 strata. All of these observational studies are from developed countries. There are none from resource-limited settings. So the NA Accord study that many of you are aware of is the one observational study that showed a benefit of early ART on death. And this is the hazard ratio here for death, and it's significant for both of these comparisons. Comparison of less than 350 versus 350 to 500. And when you compare 350 to 500 CD4 cell count at initiation versus greater than 500 CD4 cell count at initiation. So in this observational study, the higher initiation at higher levels was associated with a better survival. However, there are two other observational studies, the ART-CC cohort and HIV causal study that was just published this month or last month in the annals that did not show such a benefit on mortality. As you see here, the comparison was 250 to 350 cells versus 350 to 450. No significant difference. 350 to 450 versus 450 to 550, again, no significant difference. And similarly, with the HIV causal cohort, starting at 350 versus 500, there was also no significant difference in mortality. So the observational evidence we have for effectiveness of earlier initiation of ART based on observational studies data is mixed and only available from observational studies to date. There are studies that have been designed, though, to try to look at this question in a randomized clinical trial, which is very critical. This is the INSIGHT START study, which is enrolling currently HIV-infected ART-naive individuals with a CD4 greater than 500, and they're randomized to an early ART group to initiate ART immediately versus deferred ART to initiate when the CD4 falls to below the threshold of 350 or an AIDS event. Anticipated sample size about 4,000, And already more than 1,000 individuals have been enrolled in the study. And the endpoints are serious AIDS events, non-AIDS events, or death, which is quite important to have this composite endpoint and obviously it's a large sample size to be able to look at, to include as well death as a very important endpoint. In addition to the START study, which is being currently enrolling patients by the Insight Network, there are other studies that try to look at this question of early initiation of ART. So here, START, sample size about 4,000, 10% are anticipated to be enrolled from sub-Saharan Africa. Baseline CD4 has to be greater than 500 cells. The primary endpoint, AIDS, non-AIDS events, and mortality. And the information to be gained will really look at the effect of early ART on cardiovascular, renal, hepatic disease, and non-AIDS cancers, as well as, of course, mortality. The Temprano study being conducted by the ANRS is a smaller study aiming to enroll about 1,600 individuals, 100% from sub-Saharan Africa, with a CD4 cell count between 350 and 800. About 60% will have CD4s at baseline are greater than 500. And the primary endpoints are non-AIDS cancers and severe bacterial infections. Now, HPTN 052, the study I mentioned to you, which has enrolled 1,763 discordant couples with CD4s between 350 and 550, about 30% of this group, so it's a much smaller number, 30% of 1,700 have CD4 cell count and baseline of greater than 500. And obviously, the primary endpoint is HIV incidence in a seronegative partner, but there also information will be gained in terms of the HIV-infected partner, an effect of ART on AIDS, STIs, IRIS events, and ART toxicity. So there are ongoing studies, but I think there's a need to do more studies, and particularly, I believe, to enroll to do larger studies from less developed countries. Now let's go back about the whole issue of ART for prevention. And the conceptual framework based on the model that I showed you, the Greenwich model, is by expanding HIV testing. For people who realize they're HIV infected, they will adopt safer behaviors by the HIV infected individual, and this will be associated with decrease in HIV transmission. At the same time that these HIV positive individuals, if they're started on ART and are adherent with ART therapy, can maintain viral suppression, and that this as well will contribute to a decrease in HIV transmission. But I think the reality is much more complicated. The reality is that obviously expanding testing is not very easy. There are very interesting models of successful expansion using, for example, community mobilization just published, or I hope it's published. It is? Okay, yeah, okay. This week, HPTN 043, which is using community mobilization to expand HIV testing. There's been models of home-based testing that have been successfully done in Uganda and elsewhere. And there's also been some provider-initiated testing as well. But nonetheless, expanding testing to reach everyone who is HIV positive is a big task. In addition, of course, to enhance the prevention potential, one needs to do also some positive prevention interventions. What's most important, and I think underestimated, is the difficulty of linkage from testing to HIV care. I always say that whenever you're doing programming, it's the arrows that really do you in. It's not the boxes, it's these arrows that are much more complex. So linkage is very important, and then once people are enrolled in care, there's another important arrow, which is getting them on ART, and of course adherence with ART, if we're able to achieve the goal or the potential of HIV ART as prevention. Just a bit of data about how well are we doing in terms of HIV testing and knowledge of status. These are data from the KAIS survey in Kenya, done in from 2008. And in that particular survey, which is a random survey of population, 84% of HIV-infected adults did not know their HIV status. We also know that in the US, we estimate that about 20% of those who are HIV infected do not know their status. We have a long way to go. But even from testing, even if we're able to expand testing, there's a lot of work to get from testing to HIV care to ART initiation. And this cascade is very critical if we are to really achieve the promise of ART for the individual and ART for prevention. Both are very important. This cascade is critical for both the person who's taking the medicines as well as the potential prevention benefit. These are data from one region in Mozambique, published by Majcik and colleagues. 23,000 individuals were tested for HIV, 7,000, about 30% were found to be HIV infected. About half of them were not enrolled in HIV care, so they were lost, essentially. So only about 4,000 were enrolled in HIV care. About 3,000 of those had a CD4 cell count after enrollment, so that's 77% of those individuals. 1,500 were found to be eligible for antiretroviral initiation, and only 400 initiated ART within less than 90 days after the CD4 cell count. You can see here on this side the losses that occur in programs, and those occur in the US and many, many other countries. This is not specific for Mozambique. And these are very important things to keep in mind if we're thinking of expanding effective treatment for the individuals themselves as well as the whole promise of prevention. And I think it's important to also keep in mind of the whole, will the HIV disease stage impact this cascade? Will we be able to see better or worse outcomes in this cascade based on the stage of disease? Now here are data from the US. We can't point fingers. We're not doing well at all in the US. If we look at the estimated about 1.1 HIV infected individuals, about 75% link within 6 to 12 months of diagnosis. About 50% are not engaged in regular HIV care. And about 25% of ART eligible are not on antiretroviral therapy, and 80% of those on antiretroviral therapy have undetectable viral load. So there's also tremendous losses along the way in terms of the benefits, potential benefits for people identified to be positive, but also including those who are eligible for ART currently, but obviously also if we want to think of this as a potential prevention strategy. This is another way of looking at the data from David Burns, who published this recently, and essentially it's looking if you have 100 HIV-infected persons, and you look at the cascade and the effectiveness of our interventions in terms of linkage and initiation of treatment and so on and so forth. Overall, you find that 26% of HIV-infected persons were in care and estimated to have a viral load less than 500 copies per ml, and these are based on US data. So there are many challenges in achieving the promise of ART for prevention, and I also believe ART for the benefit of individuals with HIV. This might be too small for you to see the print, but I think there are challenges in terms of all the individuals who are unaware of their HIV status and how can we decrease that proportion of people who don't know their HIV status. This is a very important starting point for the cascade. Limited access to testing, issues of stigma, denial, provider practice of being reluctant to offer routine testing, routine screening, as well as many, many other issues. Late diagnosis of HIV disease has major implications, the failure of HIV positives to link to care, and there are many barriers in the system and for the individuals themselves. Late initiation of antiretroviral therapy due to provider bias, provider lack of knowledge or their belief systems, as well as, of course, the limited treatment literacy and fear of ART among some patients. And lastly, the inability to maintain viral suppression, although we're doing better at maintaining viral suppression with the availability of effective treatment, but that requires retaining people in care and for the long time, for their life, essentially. And the importance of support for adherence and support for overcoming some of the other barriers like substance use and so on. So I think these are the impediments in the cascade, and I think if we are to get to the promise of ART for individuals with HIV as well as for prevention, these are the kind of building blocks of the cascade that we need to focus on in order to achieve the best and optimal outcomes. Now, in the US, there's a study that's ongoing now, HPTN 065 or TLC+, that's funded by NIH, but is being done in collaboration with the CDC and with departments of health in 6 cities in the US. And the purpose is to demonstrate the feasibility of an enhanced community-level HIV test linked to care plus treat strategy in the US. And the study is really focusing on the pieces of this cascade that are very thorny and difficult. So it's a component of HIV testing, and I think it's a model of how we need to look at studies that try to address this whole issue. Is we have to think of this cascade. So one piece is expanding HIV testing through social mobilization in 2 intervention communities, the Bronx and Washington, D.C. Universal offer of testing in emergency department hospital admissions because they have a high utilization rate and also a high yield of HIV positive. And then for linkage to care, we're utilizing an innovative approach, randomizing sites, HIV test sites, to financial incentive to promote linkage to care versus standard of care. And for viral suppression, we're randomizing the HIV care sites, not individual randomization, but site randomization, to financial incentive to achieve and maintain viral suppression versus standard of care. There's also an individual randomization for prevention and positive of a computer-based self-directed intervention for positive prevention versus standard of care. We're also doing now, and we have done, a baseline provider and patient survey to gather the knowledge and attitudes regarding the early use of antiretroviral therapy, use of antiretroviral therapy for prevention, as well as obviously attitudes and beliefs regarding the use of financial incentives, which is there's a lot of interest in utilizing this type of structural intervention. So I guess I believe that ART for prevention, as well as ART for care, is really a multi-component strategy. It's not just a drug and ART. It is a whole. There are many elements of this strategy that we should keep in mind, and this is the same, whether it be for treatment or for prevention. It's almost a unifying frame. We have to expand testing to get most people into care and treatment. We have to link to care, initiate antiretroviral therapy, obviously, based on whatever threshold, whatever guidelines there are, adherence support, and positive prevention for those who are positive. I think it is by itself a combination strategy. Just ART for prevention is a combination strategy. Now, we have a long way to go in terms of HIV treatment coverage in the world, and you probably saw this last night. I came late, but we know that it's estimated not even 40% of people who need ART today in sub-Saharan Africa, and even smaller proportions in other parts of the world, are getting access to antiretroviral therapy. Even if we reach the people who need treatment, if we just reach the people who need treatment today, we might have a major impact, obviously, on their morbidity and mortality, but also we're likely to have an impact on prevention as well. So even if we reach the people who need treatment today, we could have a huge impact, and I think this is very important. Something that I often talk about when I speak in the countries themselves is that you can do a lot by just reaching the people who are eligible today. There's been some modeling that has been done to look at various scenarios of whether you treat everybody and what would happen if you treat everybody. And I think I don't have time, but in black here, this is the trajectory of annual incidence, but also other scenarios that some would say are more realistic, maybe, of looking at treating 65% of those who are symptomatic and 20% of those who are asymptomatic, with the dropout rates that are much more realistic, but not very good, of 5% loss to follow-up in the symptomatic versus 20% in the asymptomatic. And another scenario here in green, another maybe pragmatic scenario of looking at treating 65% of those who are symptomatic and no ART for asymptomatic. Each of these strategies has its pros and cons, and I think it's important to keep in mind what are we trying to achieve, how can we achieve it, what does the evidence support, where should we immediately start, and where should we push. And I think we need the models to assist us, but also I think we need to collect true empiric data in order to validate some of these assumptions. But there are ways of thinking about expansion of ART for treatment and for prevention in different ways, based on assumptions and based on what our goals are. So in conclusion, the findings from observational and ecological studies support the role for ART as a prevention intervention. Compelling findings, I showed you some compelling findings from discordant couple studies to date. Findings from a definitive randomized trial are awaited, HPTN 052. I think the important issue is the whole issue of the contribution of discordant couples to HIV incidence is likely to vary substantially from one setting to another. And I think what's going to be very important is that to build on the evidence and to really think about the next step. The next step is to take this hypothesis and try to understand what would be the impact on a population level in terms of HIV incidence. The benefits and risks of early ART for persons living with HIV need to be rigorously evaluated. There is some evidence, obviously, and the pathogenetic hypothesis of inflammation and stimulation of coagulation cascade are very important. But the impact of ART on shutting down this cascade remain to be determined. And particularly, I think, the role of ART in very early HIV disease remains to be studied, particularly, I think, in developing countries where there are no data at all. And obviously, there are ongoing clinical trials that will hopefully help inform this issue, and more are needed desperately. Achieving the potential of benefits for ART, and I think both for treatment and for prevention, will require a multitude of other intervention, expansion of testing, the linkage to care, the retention, adherence, as well as, of course, positive prevention intervention. So it's a complex combination strategy. I believe you must keep the momentum to provide access to ART for persons living with HIV who need treatment today, both in terms of their own benefit, obviously, but I think also in terms of the potential for ART for prevention, just by focusing on the people we have to reach today. There's also a need for population-level studies to determine the feasibility and the effectiveness of ART as a prevention intervention, and I know that the HPTN 065 and there are other studies, feasibility studies that are in development that you will hear about at this meeting that are being planned at this point in time, and more need to be planned urgently. And I think ultimate control of HIV, I believe, will require multi-intervention strategies inclusive of the use of ART for individuals as well, for individual benefit and societal benefit. So I think there's this balance that we struggle with. I think it's kind of the balance between the benefits and risks to the individual versus the benefits and risks to societies. And this is not something new. I think this is something we've struggled with for a long time. And I think particularly for those who are clinicians in the room who struggle with, what to advise the patients, what's for them versus what is for the benefit of their partner and the benefit of societies. These are not easy questions. I don't have the answer, but I think we need to keep them in mind as we push on getting evidence to support both sides of this balance. I think that will be very, very important and should be at the center of our work. We need to be keeping in mind that in order to achieve the promise of ART for prevention, we really need to also think about the people who are taking the ART. Finally, thank you very much for your attention.